That's because I wanted a more intrusive vector on this side to pull up the occlusal plane and correct the cant. Now, this will be finished. Now I finish on a 21 by 25 stainless steel. I have never used a TMA wire. Dr. Pao uses them a lot, but I don't use TMAs. I go in from a night eye. My sequence is usually I start with an 014 night eye. I go into a 1622 thermal night eye, maybe an 1825 night eye, and then I jump into a 1925 stainless steel, and then finish on a 21 by 25 stainless steel. Not all the time, maybe about 70% of the time. The rest of it, I finish on a 1925 night eye, because that helps me move the roots back. Because once you finish space closure, you tend to bend the roots. You see, there's always a vertical bowing effect when you pull back, right? Let's imagine. So can you imagine when I'm pulling from here to here, there is always a tendency of the posteriors to bend vertically, and you find a posterior open bite kind of a thing forming, and when that happens, the wire is not going to slide anymore, because there is too much of a friction here at the end. That's at this area. Imagine the wire bending like this, and it's going here, so it won't slide through the back, right? And when that happens, you need to know that you need to change the wire. You need to flatten out the curve again, and then you need to start the sliding all over again. Now I go around it. What I usually do is I use an accentuated curve of speed on the upper, on a retraction wire. So on a 1925, I'm explaining all these things because I won't have to explain them in the next coming cases, so that you already know what I'm exactly saying. So this is the retraction wire again. In the upper, an accentuated curve of speed is like this. On the lower, a reverse curve is like this, right? So I bend the wire, yeah, here. I bend the wire like this. It's a curve here, and on the lower, it's a curve like this, right? So the end result is going to be bite opening. Now usually when we retract, have you noticed the gummy smile at the end of space closure, right? That's very common. Now the reason of the gummy smile, people would think, is mostly extrusion of the incisors because of the dumping, right? Well, that's a part of it. But usually what happens is we have very less posterior control while retracting. As you can see, whenever we retract, especially here, there is a distal tip and there's an extrusive force when we retract because of the bending, right? Now that ends up in extrusion of the molars, that ends up in increase of the angle of the mandible, counterclockwise rotation of a mandible on a class 2, right? And so we have a bite opening already, and to compensate for that, the anteriors extrude. And that is the reason why we have a gummy smile almost all the time when we finish an extraction case. And some of the patients say that, doctor, we started normal, I had this problem, but now, yeah, I understand my lips have gone back, but I have a gummy smile. So what do we do about that, right?
Use your mic.
Yeah. So, you can counter that effect by using an accentuated curve of SPI on the upper and a reverse curve of SPI on the lower. It's a gradual, it's not a gable bend, it's a gradual curve that you put in. So when you insert the wire on the posteriors, the wire in the front goes up, right? And then you pull it down and engage it onto the uppers. Same on the lower, you put it in, the wire goes here, you pull it up and fix it there. So that gives you an opening effect while retraction. The other thing it does is, just try to imagine these things. I was talking about the torque loss, remember? Right? Whenever you have an intrusive force, like an accentuated curve of SPI on the upper and the reverse on the lower, you see the vector, imagine the wire coming like this, right? And on the upper, imagine the wire going up. When you pull it down and engage it on the brackets, don't you think it's also giving a forward rotation? It is not just an intrusion. it can never be just intrusion. It's always going to be a counterclockwise rotation of the incisors, right? And that is going to give you a positive torque while retracting and won't let the anteriors dump. So there are 2 or 3 things which happen simultaneously just by a very simple thing. That's an accentuated curve P on the upper and lower, right? So that's that. And this was the end. You see the profile change, right? It's profound. Now, the reasons why this happened is because I had a very good vertical control. Vertical control, in the sense, is that especially the posteriors need to be controlled. As I mentioned, if the posteriors extrude, the angle increases, right? Try to imagine on a class 2 skeletal, what kind of mandibular motion is beneficial to you? Is it counterclockwise or is it clockwise? Can someone tell me that? Are you able to comprehend what I'm saying? Yeah? So, in a class 2, try to imagine that the mandible is slightly behind the maxilla, isn't it? What kind of rotation of the mandible would be better? You want the mandible to go forward or backward? Forward. Now, forward is always with upward. Forward is never with downward unless it's growth, right? So forward is always with upward, and that is counterclockwise. Downward is always with backward, that is counterclockwise, right? So you don't want a counterclockwise motion of the mandible on a class 2. You want a counterclockwise, you don't want a clockwise motion, right?
Yep.
Now that you can achieve by intruding the posteriors. Intrusion of the upper posteriors would let you counterclockwise move the mandible upward and forward, getting a better chin position, right? I will show you an example in which I did not move the molars, and I straightened the face and everything, but then I didn't like the profile much. I will show you an example. Now this is a good example. I couldn't do the superimpositions of this case because when I finished, she was pregnant already, so I couldn't take the x-rays. Now the key again is the vertical dimension, especially when you're doing an extraction case. Let's talk about this case. Now this is again the good rotation that I'm talking about. Let's talk about it. What do you think is the main problem here? Especially a patient of this sort comes to you, you already know why she has come to you, right? It's less of the teeth and more of the face that she wants a correction with. High angle, she wanted her lips and her lower face to look much better, right? When you see such a case, it's class 1 canines, it's a little bit of crowding on the upper and on the lower. Now I decided to extract again on this case. I'm sure anyone would extract, right? On this particular case. Yeah, for me, it's very simple. I don't go in for much of the non-extraction protocol because you can say that I'm a tweed guy. So if it's very simple, I do believe that the arch must not be expanded, number 1. I do believe that the IMPA, that the lower incisors are not to be proclined. It has to be around the norms for that race. And if it is not, it's not stable. So these are the, and the third is definitely the vertical control. The vertical control has to be done in every case. If you rotate it, it's not stable. Again, these are the 3 most fundamental rules of tweed. So in this case, I used an appliance because I tried placing the mini screw many times and it failed. Now, it may have been an error on my side. It may have been the hygiene. It can be many reasons. I can't point out as to why the tag failed. And so I decided to just modify this particular appliance a little bit in order to add anchorage. Extraction of first premolars done, and a TPA with an extension towards the premolars, and added some flow composite on the crowns, right, to just build up the anchorage a little bit. Now, on the lower, the implants were pretty stable because the bone physiology is a little different on the lower. It's dense cortical bone, right? So that's why a smaller length is okay on the lower. You don't need to really dig in with a very long implant. You can just go for a short one. On the lower, it almost stays stable. But evidence suggests that the implants on the lowers fail more, because the first reason is that the mucogingival junction, right? That's a little higher, and moreover, the bone is pretty thick. So when you're inserting, the heat generated is a lot, right? And these are the two reasons basically why the lower implants fail more compared to the upper. But that's according to evidence. That's RCTs for you. My personal experience, the upper fails more. So yeah, so basically it's the same thing, same mechanics, everything the same. It's just that on the upper I've used an appliance instead of tags. And yeah, I need to show you this. Yeah, this hook that you can see over here has been placed at the level of the tags, right? Just to go up there. And I use this to pull. So I place a power chain from here, going straight there. And the hook is always placed between the lateral and the canine, right? Now, there is a reason as to why the hook is placed over there. Now, ideally, the center of resistance of the canine to canine segment is behind the canines, just behind the canines, right? But we place it between the laterals and the canines for a reason, is that if you place it distal to the canine and you start pulling back, right? There is this small space that is going to be left at the back, and you'll anyways have to use a power chain or something. So conveniently, we place it there, in front of the canine, which really doesn't make much of a difference clinically. Yeah. And then I settle, I usually settle with Inter-Maxillary Elastics. I use a lot of elastics as well. Now most commonly I go in for rabbit in Omco, that is 3x16 medium, chipmunk 1x8 medium, and in the early stages, in the initial stages, I use a lot of light elastics. That's 2.5 ounce, 2 ounce elastics. But in the later stages, I use medium. I never go to heavy. I don't use heavy elastics. Yeah. Now there is another knack of settling well, is sometimes I take off the wires at the back. I keep only the canine to canine segment on, and at the back there is no wire. And I use the elastics directly, up and down, right? But you must do that only if you have a vertical problem. Nothing transfers. If you have a transfers issue, you're going to change the torque, right? And then you'll have to re-level again. The whole point is gone. So you have to be very careful when you do that. I settle for about, say, 2 months or 1 month before debonding. And that's the reason I go into a night eye again. You see? Because night eye would straighten all the roots again. And it would make it parallel, because I'm on a thick 1925 night eye on finishing. So that would straighten up the roots and would give me parallel roots. And also, it eases up the movement with elastics. If you have a very rigid 21x25 stainless steel, do you think that it's going to move if you put elastics? It won't. It's too hard, right? It's too strong. The 1x8, the small elastic, it's not going to move it anymore. You need a light wire for the elastics to start working. Now you can't go into a 1-4 night eye also, but the least you can do is go into a night eye at least, or a TMA as he uses. Yeah, so this was the finish, and let me show you this. You see this is what I'm talking about. Now here in the superimposition, it's very clear that the appliance did not give me maximum anchorage. It gave me moderate anchorage. You can see half the molar is moved forward. But please try to understand that even with half the molars moving forward, that is about, say, 3 millimeters of anchorage loss, I got a beautiful profile change. So that means to say that you don't always need maximum anchorage, right? Especially on girls, especially on women, young women. I have realized, and there are many studies about it in angle as well, that a lot of pulling back would make their face look too flat and make them about 10 years older. For men, that does not hold true, because our bony structure is a little different. But for women, it makes a lot of difference. So after the next case, I have in fact stopped the concept of maximum anchorage on women, because I realized that if you bond 2 molars and you pull back the canine to canine segment, you get enough retraction, you get enough profile change on an Asian profile. Let me clarify, on an Asian profile. I'm not talking about a Caucasian, I'm not talking about an Afro-American or an African, no. It's about an Asian profile that I'm talking about right now. That possibly you can get a lot of profile change, right? See this? Now, rotation of the mandible counterclockwise, right? Has, along with retraction, has given her a better profile. If it was just pull back in the sagittal plane, she would have looked older because her angle would have increased further, right? It would have gone back. This would have gone back all the more, and this would have come back. She would look really old, and I'll give you an example. The next case is going to be just an example of how I screwed up. So aesthetic considerations of class 2, desired counterclockwise rotation of the mandible, avoiding extrusion of upper incisors leading to a gummy smile, an ideal lip position. So these are the 3 goals I usually go to when I'm correcting a class 2. Now this is a case of a borderline class 3. Now, what would you do with this case? Extraction, non-extraction. The patient's problem, the patient's complaint was her lips, not her teeth, right? What would you do with this? Go on. You see the canines? Yeah, they're very easy to correct, right? Non-extraction. You can just use some elastics and get it to a class 1. You have space in the front, you can just retract them, get an ideal overjet and call it a day. It's easy. It would take me less than a year to probably finish this case if I would have done it that way. But then, do you think you can correct this part? Can you correct this? Just a 2 millimeter retraction, right? Would not correct the lips. You would need a lot of retraction over here. So, extraction again. But then in this case, I did not correct the vertical. I did not take care of the vertical positions of the molars, and I just simply leveled, implants, pull back, close the space. Now, please remember and notice this picture, this lower picture. She looks good here, right? The frontal looks good. The problem is this, right? So now we need to differentiate between the frontal and the sagittal. Sometimes they don't go along together. It's not the same. You have to really take care of it in a different way. So again, extractions, 4 implants, and I probably didn't have hooks, so I bent the hooks on the wire itself and started pulling back here. Now, please don't confuse this with posterior intrusion. This was just because I extracted before leveling. I didn't want the molars to move forward, and so I placed the implants and I just tied a ligature there so that the molars didn't move forward and I didn't lose anchorage. I'm not actively intruding in this case, and that's probably the mistake I made. I should have. So it's very simple. I mean, just use those implants and pull back. Now please see this. Space is closed, but yeah. Now notice this. You see this? Right? Do you notice this? Just try to imagine, remember this. And remember this. See this? She looks old. I finished that treatment in 1 year. I made her 10 years older in 1 year. So now you see, it's all up to us, right? We can not. The problem is, but the good thing is, not the problem is. The good thing is that she's happy. She is okay with it. I mean, all she wanted was her lips to go back, and she is not able to understand the concept of the vertical increasing and she looking old as of now. But yeah, probably 10 of her friends are going to tell her that, oh, you're looking old, and then she's going to come back to me. And at that time, probably I can't do much of it because I've already extracted, right? So just remember that. You don't need to pull back completely, right? Especially on a middle-aged, young Asian girl or lady, you don't need to do that. 2 molars are more than enough, but control the vertical, right? Make sure that they don't just dump in and come down, or else you're going to create a gummy smile. You're going to create an occlusal plane which is downward, and that's wrong. Not stable. Okay. So as you can see over here, the same thing. Too much pullback. Now, I'm going to be showing you now examples of some cases in which, these are extraction cases again, in which I have done things a little differently. I have leveled and closed spaces simultaneously, right? Now, it doesn't work all the time because of the fact that your teeth basically need to reach an appropriate angulation before they can be pulled back, or else they will dump. Many things are going to happen. You need to really level them, right? But there are these cases in which, anyways, I'm going to talk about it as and when we progress with the cases. So this is a case of a skeletal class 3 with a very, it's heavily crowded upper and lower arch. Extractions, of course. Now, this was a transfer case. In the beginning, I had, the doctor had placed this, an open coil spring, extracted the premolars, and of course, this seems like the normal thing to do, isn't it? You place open coil springs and you try to retract the canines, make space for the lateral incisors in the beginning, and then you get the laterals out and all those things. But then what happens is, how do you control this from going forward? This would go forward, right? Now there are 2 ways of doing it. One is if you're using an Mbt bracket, right? An Mbt bracket, the torque is pretty high on the uppers. I think it's about 14 or 11 to 14 degrees. So when you reverse the torque, when you reverse the bracket, so when you reverse the bracket, you get minus 14, right? And when you get minus 14, you can use a 1425 night eye wire, because that has the 25 side as well there, which would express the torque. You can use the 1425 with the open coil spring. So that would dislice the canines, and that would not let the 2 central incisors procline too much because of the negative inbuilt torque, right? Because you reverse the Mbt bracket. The other easy way of doing it is you can just put some flow composite over here, here, and not let the spring touch the central incisor, the distal end of the brackets of the central incisor. But in my experience, that doesn't work really well. Somehow still the wire bends, right? Because the force is on the wire, and that pushes the tooth forward, even though it's not touching it. So what I decided to do is, you see this angulation, you see the angulation of the central incisors in the first and the second pick? They're really flared out, but nothing much can be done about it because it's already flared out. So then I decided to put in these loops. Now my idea was, I was just giving it a try. These loops over here, all of them are closing loops. That means what you're seeing right now is the active form of it. It's not the passive form, right? Now this loop is not open. This is a closing loop. This is a bull loop, which is now open. When I push it in, you see the stop loop here? It's tied back, right? That means the stop loop is here. I have tied it back with a ligature. So this is open now, and this is open. This is open. So what I tried is to level and simultaneously use those spaces to pull back the incisors as well and get the canines back into the right position. Now, as you can see here, this is the first this is when I got it, and this is when I placed the wire inside. You can see the box loops, right? So these box loops are getting the lateral out in a 3-dimensional plane. At the same time, they are closing the spaces, right? They're closing the spaces over here. And this is 2 months apart. So 2 or 3 months, I think, 3 months apart. And then I went on to an overlay wire, and then into a hard stainless steel. So And she needed some amount of gum contouring as well. So we did that. Now I am not very good at the general stuff, so I have someone doing it for me, everything in terms of restorations and the gum contouring and all those things. So yeah. So this is one way with the loops, right? That you can manage. If you're very good at loops, you can try. You can try in cases with some heavy crowding, mild to moderate crowding with some spaces, right? All you have to do is think as to what kind of forces are you generating, right? Are they the right kind of forces? Now there are cases in which this probably wouldn't work. The lateral would not come out because there's too much force in the centrals to come back, right? So that might happen. You might have to go into the other mechanics again, like I mentioned in the beginning. But all you have to do is when you're using something like this, when you're bringing out locked lateral incisors, it's paramount that you control the central incisors. That's very, very important, because the first thing we do is, oh, let's put an open coil spring over there, and then you realize that yes, I got the space, but it's not the space by distalizing the canines. Half the space is by proclining the central incisors outside, right? And then you're round tripping by again pulling those central incisors back, but half the space has already been lost, right? So your extraction is a waste. So basically you need to use the extraction space to your maximum benefit. That's really important. Now, that was with the loops, and so I decided to try it with tags. Now this is a case of a young girl. I think she was 14 years old, I suppose, yeah. You see the malocclusion, she has 2 teeth missing on the lower, right? She has a fairly straight arch on the lower. Her upper is really crowded, and she has too many teeth on the upper to fit the lower, right? The profile looks like it's a non-extraction profile, but if you try to do this non-extraction, you're going to really expand the upper arch. It's not going to fit the lower anymore, because there is a TLD here. There's a tooth material and arch length discrepancy, right? That's a very big thing. You need to really match the amount of teeth first. One more thing, let me just tell you, is that doing a case non-extraction, people might think is very easy. It's in fact not easy. It's very hard. It's doing a case non-extraction, especially if that case is an extraction case. Now what we try to do is we try to make it easy by just putting the brackets and leveling it, but then it never turns out good. It's so difficult to finish those cases. The teeth go forward, and you will always have a Bolton's issue. The settling is very hard. You create a lot of other issues. Extraction is the easy way out, right? And it controls it. I mean, if you have to extract, please extract. There's no other way around it. Yeah, so again, let's see, canines class 2, molars almost class 1, lower, no crowding, upper, moderate crowding. I decided to extract the upper force in this case, and the patient was in a hurry. She was going to the States to study, and she had, I think, about a year and a half. But then telling her that I would finish it in a year and a half would be a little, would be pushing it. What if I'm not? So I decided to just try something. Now, please follow me when I say this. Now I did not place the brackets in the lower, considering the fact that the lowers are good. If I place the brackets on the lower, I would be proclining the lower teeth unnecessarily when the angulations are good. I'm trying to bring the upper back to the level of the lower, not get the lower to the level of the upper. So I decided not to place the brackets on the lower till the end, to close these minor spaces. That's about it. Now, I placed the tags at day 1, extracted at day 1. This is an 014 NITI, and I placed a loose. It's a lace back. It's not a tight ligature tie. It's a very loose lace back from the canine